Welcome to today's webinar resident series, Restorative Crown and Bridge from Material Choice to Patient Acceptance. It is being presented by Tremaine Watkins, CDT, Clinical Director of Guided Surgery and Implant Solutions. That it is my pleasure to introduce Adam Dreyfus, Director, University, Government, and Institutions. Take it away, Adam.
Oh, good morning, and thank you so much, Jessica, for the warm welcome, and happy Valentine's Day to you, and to you, Tremaine, and to everyone attending. I first want to say thank you. Thank you to all of you for your continued partnership, support. Myself, NDX, the education team, our operations team, the entire organization really appreciates the partnership that we have formed with you, and we really are open to hearing your suggestions. This is for you. We do this to really aid in some of the skills that you're learning in your residency, really enforce what you've learned in your dental school experience. And we're just here as another resource. As I always say, we're here for you today, tomorrow, and for the future. And we truly, truly do mean that. I will come back on at the end of the presentation, but I don't want to take any time away from the maestro himself. So without further ado, Tremaine Watkins, please take it away.
Morning, everybody. Thanks, like Adam said, for attending. We're looking forward to hopefully a good presentation today. So today we're going to be talking about case planning and material selection for tooth-supported cases. We want to focus on treatment planning that affects smaller cases like single anterior restorations, but especially for cases that are larger. And to understand this, think about a single crown like a number 8 as opposed to a 6-unit anterior bridge with 4 ponics. I think most of us would say that the shade accuracy of the number 8 case is going to be very, very difficult. That'll probably be the hardest part of the case. But in terms of tooth position, morphology, emergence profiles, those kind of things, it's pretty straightforward because we're trying to mirror the tooth. On the other hand, if you transition to a larger restoration like that 6-unit bridge, you have to deal with where are your ponic positions, where do you position the midline, emergence profiles, how you set the ponics on the ridge, different things like that. So today we're going to be talking about case planning, focusing more on larger tooth-borne cases, but then we'll also, I think you'll be able to apply a lot of these to your smaller cases as well. So as you know, and we'll be talking about this quite a bit, it's really important to have a team when you're trying to deal with full arch cases. Most of these cases have a multidisciplinary element to them. As the general dentist, you'll be the one kind of leading the charge, but you'll want to have a team of both specialists and laboratory folks who can help implement specific parts of the plan. I think this part is often overlooked in treatment. Every comprehensive case begins with a thorough understanding of the patient's desired outcome. You know, when I think about cases in my own career that have gone so badly that I still remember them many years later, communication was really the foundational problem. Either we didn't understand what the patient's expectations were, we didn't take the time to really understand it, or as a laboratory, we didn't do a good job of communicating with the clinician, like what could actually be done. And I'd say there's a corollary to that. In my opinion, this is the golden age of restorative dentistry. When I was young, before implants were so prevalent, there were a lot of cases where we really didn't have an awesome prosthetic solution. I mean, if a person was edentulous in the maxillary posterior, really our best option was a fixed bridge in the anterior or precision partial. Those things were hard to do, and they really didn't look that awesome. So it's like we worked hard and came out with a kind of an okay result. Today, there are few people who cannot get exactly the result that they want. But now it becomes more challenging for us as a treatment team. We have to understand what options are out there, and then we have to be able to kind of pivot and alter what we choose to do based on the patient's options. So we want to use our active listening to hear what the patient says and repeat back to them to make sure that we understand what they're saying. And then we kind of need to be flexible because some of the more awesome treatments that are available are also very expensive, and maybe our patients can't afford it, or maybe we need to help them some financing options. And we also need to present things in a way that's clear to them. In dentistry, as with most precise fields, we have a variety of different words we can use that can sometimes seem like jargon. And so what we need to do is make sure we use our words to effectively, in a way so that our patients understand what we're trying to tell them. If the patient tells us what they want, we understand what they want, and then we present any challenges, I believe it sets a foundation for success. And we'll kind of talk through that as we're going along. Ooh, excuse me. So comprehensive dental treatment is expensive, as we mentioned. There are a proliferation of options more than ever before. But a lot of times we're going to want to do staged treatment, and cost isn't the only option. Sometimes we'll want to do some work with the occlusion before we move forward. Sometimes we need to do surgical treatments. It'll take some time. And one of the important aspects of this is to be thinking about how is the patient's dental experience going to be while the implants are healing, while we're doing orthodontia, while we're doing extractions, while we're shaping chronic site, things that take some time. And we want to communicate that as well. Some of our patients are going to be like, okay, I want to do the least expensive or the least invasive option. And in some ways, those can be a little bit easier. Some of our patients are going to be like, I want everything to look awesome all the way through. And I think we have that ability, but we really need to think about what we need to do that. For instance, let's say we're doing a full arch and we're opening the bite and the patient decides they want to do it in 3 segments. Well, we should probably talk to our patient and say, hey, when we get the maxillary anterior teeth in the proper position, and we do posterior bondings, you're going to see a little bit of a color line between those bondings and your teeth. Are you going to be okay with that? Or would you prefer that we provisionalize all your teeth at the same time? We just really need to make sure that when we're communicating with our patients, we understand like how we're going to stage the case and what the patient experience variables might be. Photography is really, really important in comprehensive dentistry, as I'm sure you've heard. Today, I think we're on the cusp of 3D facial scanning. In your career, you will probably get to the case where you don't do photos anymore, where you submit a 3D, an STL of the patient's face, and the case is actually designed in the patient's face. Today, I would say that's still kind of a novel workflow, and most offices are going to be communicating via photos. We need a few photos in the laboratory to do a really good job. We need a relaxed lip image to see the maxillary incisal edge position. We'll talk about how important that is. Normal smile to see buccal corridor and our incisal edge and midline, that sort of thing. And then we need a Duchenne smile to look at gingival display. For your patients who have terminal dentition and different things like that, or maybe where you're doing a hybrid, make sure that you do whatever you have to do to get them to give their true high smile. A lot of these patients have trained themselves not to show their teeth. We need to help them. Retracted views, which I have a lot here, are helpful for diagnosis, but they're not as helpful in the laboratory because we're really trying to see the teeth relative to the face. Photos are also critical for shade taking, obviously. The first thing I would say that's probably a bit of a paradigm shift is we want to take the photo first when we're doing treatment. Even with single teeth, we don't want to prep first and photo second because the teeth dehydrate and then our photos aren't as accurate. The second thing is we need to think about our environment. Color is not like mass. It is not an intrinsic property of something. Rather, it's the way that a given material interacts with its environment. And so the first thing is, if we want to see true color, we have to have the full spectrum of light. So when you're looking at the lights in your operatory, especially in the operatories where you're taking shades, you want to make sure that the color rendering index, sometimes called the CRI, is very high. It's the percentage of the spectrum of visible light that a bulb emits. You should have 95 or higher when you're taking shades. Second thing we want to think about is our eyes, is that our eyes are a very delicate but accurate shade-taking instrument. Us men, 1 in 12 of us are colorblind, so we should probably test ourselves with some simple online tests to make sure we can actually see color. 1 in 200 women are affected, so it's much more rare. The other thing to keep in mind is that our eyes are easily overwhelmed. Even if we have the right color of light, the intensity of the light is really important. So in other words, taking shades with an operative light, even if it's allegedly color correct, not a good idea. It'll overpower our eyes. The other thing to keep in mind is automated shade taking. I've used some. It seems like it's a thing that kind of comes and goes. We haven't heard as much about it lately. But what we've seen historically is that spectrophotometers and colorimeters, which are kind of the two technologies, they're not as good at seeing translucency. So they'll give you an approximation. They're good for posterior teeth, but when you're trying to get a good shade on an anterior tooth, especially for a single anterior, you need to use your own eyes. If you're taking precision shades, you want to keep in mind that as you look at your patient, you'll find that most people's teeth have a slight variation in color from one to the other. What I found, I've done a lot of these, is that it's very challenging. When you first start, you're like, well, I'm doing number 8, so I'll match number 9. But a lot of times, sometimes number 9 is the darkest tooth in the person's head. So it makes their smile less attractive. So one of the things you want to talk about when you talk to your patient is not to make them self-conscious, but just to say, hey, you have a variety of colors in your mouth. Let me show you this and this and this. I think that if we match this one, it'll give you the best result and it'll make your smile look the best at the end. And if they say, oh, that stinks, well, I don't want all my teeth looking different, this is a great time to talk about what you can do with comprehensive dentistry to correct that. When we do custom shades in the labs, it's primarily precision photo taking. So you can get the same results clinically for your laboratory. But you need to take a nice photo like this. And there are a few tricks, I would say, that are really important. The first is that you want to get a shade tab that is within half a shade of the tooth. It doesn't have to be a perfect match, but you want your shade tab to be within half a shade of the body shade. And you want it to be a shade that's either common, like one of the Vita shades or Bioform or something, or send it to the laboratory. If you have like a composite shade tab or something, no problem. Make sure you send it along with your photos. If you have intense gingival colorations or unusual translucencies, you may want to use auxiliary shade tabs for that. So that's important. This is really important. Getting the shade tab in the same plane as the tooth that you're measuring. See how the buccal surfaces of this shade tab and the tooth are aligned? What I've seen as we've transitioned from DSLR cameras to mostly phones is that phones are really, really prone to taking poor pictures if the shade tab is even a little bit misaligned. So whoever's taking the photo, somebody else should hold the shade tab to make sure it's in the perfect position. Want you to take your photos from a variety of angles so that you can control the reflection. And then when you're done, I try to take about 14 or 15 photos for a important shade. And what I'll do is I'll flip through them and narrow down to about 3 that I feel like best reflect actually what I'm seeing in reality. When you look through your photos, you'll be amazed how different they can be from reality. So make sure you only send the ones that show kind of what you want. You guys do a lot with radiographs. I'm not going to tell you anything you don't know, but you kind of want to think about the prosthetic and restorative implications of the radiographs that you're seeing. Of course, we want to evaluate our teeth and decide which are stable and which are not. We'll talk about that a little bit more. But like this case, for instance, we're going to have to extract those 2 incisors. But we need to think about what happens. When we extract those incisors, the tissue is going to follow the bone and it's going to collapse. We're going to have a very large defect in that area. So what we need to do is we need to talk to the patient. We can say, hey, we have a variety of options for you. We can do bone grafting and some soft tissue grafting to get a nice gingival, kind of show them how you would align the free gingival margin with the adjacent teeth. You can talk to them about pink porcelain, but keep in mind that especially with a small segment of pink porcelain like this, you're going to have a seam all the way around it that the person can see. A lot of times pink porcelain is treated like a silver bullet and it really isn't. I would say it's a tool, but make sure when you're talking about pink porcelain, you underpromise and overdeliver. That's really important. The other thing is you really need to work with your laboratory on deciding how the pink porcelain is going to be configured. The more it's adapted to the gingiva, the greater the buccal ridge lap on it, and it really creates hygiene issues. So again, we were talking about basically at the beginning presenting value. This is a great way to present value because grafting and the tissue augmentation is going to be a little more expensive, but it's definitely going to give a much nicer result. And so you present that to the patient, you present the pink porcelain, and then when they make their decision, that's great, but they've been involved in the treatment, and then they'll be more satisfied with the result. So we also want to, of course, evaluate the endodontic situation for various teeth. But I think one of the things that we sometimes don't do as well is to talk to our patients about probabilities. In other words, if we look at a tooth and we're like, well, yes, we could save this endodontically, but we're probably not, we're going to get 5 years out of it or 3 years or whatever. I mean, I feel like that's an important conversation to have with the patient. And again, of course, we can say, this is based on my training and expertise experience, maybe a little bit different, but I think we should present the best option for our patient. And one of the things we want to keep in mind is even crown and bridge. Studies have shown that at 10 years, a 3-unit bridge, most 3-unit bridges have failed. A 3-unit bridge has a life expectancy of 8.3 to 10.3 years. On the other hand, a single implant at 10 years has a 95% success rate. So these are some of, and I mean, obviously a 3-unit bridge is a best case scenario. If we add more ponics, every ponic we add adds 8 times the load. So in other words, biomechanically, we're putting a lot more load and probably increasing failure. And if we have to use a cantilever, so much the worse. So we also need to think about the abutment teeth for a bridge and how we're going to, that if we have to prepare a virgin tooth, that's, we'd like to avoid that. So again, I think that when we're doing our diagnosis, especially we're looking at the results of our radiographic analysis, we need to, really think about it from the patient's perspective and say, okay, we can do this and we can do this and we can do this. These are the long-term prognoses I see for each of those. And again, it's not about sales, but it's about keeping the patient involved. So that way, as the results emerge, it not only builds your credibility with the patients in your practice over time, but it also helps your patient to make responsible choices so that they understand the results of what they choose when they're doing their dental treatment. I would say in the 21st century, osseointegrated root form implants are the treatment of choice for missing teeth in almost all circumstances. Last month, we talked quite a bit about bite, so I don't want to beat that to death, but what I do want to say is that when we're doing comprehensive treatment, many of our patients have lost vertical dimension of occlusion, and their CRCO may not be coincident. They may be symptomatic in their TMJ. So we really want to make a thorough analysis of their current bite situation and where we want to go with this. One of the things we'll talk about is how we use our models to establish the bite, and then we're just going to carry that bite forward all the way through treatment. So we're going to want to look at our incisal edge position and kind of our initial impressions. We talked about this before, but it bears mentioning again that the incisal edge position of number 8 and 9 dictates our treatment for the whole rest of the case. It looks youthful, and so most people consider it attractive to show 1 to 2 millimeters of incisal edge with the upper lip at rest. So this is the point where you take your initial models for your laboratory. And so you want to take them either with an iOS or with VPS or polyether, and you really want to capture the whole oral situation. In other words, if you're doing the maxilla, make sure you capture the palate, make sure you capture the vestibule. On the mandible, make sure you capture all the vestibules, the retromolar pad. we'll be using these models as kind of our foundation for our bite, and we want to make sure they're as accurate as possible. And the other thing is we want to take some nice photos, and then you can articulate from the study model where we need to be. So in other words, like let's say we couldn't see the incisal edge of this person's teeth, and you noticed that they were 1 millimeter above the relaxed lip position. So you would say to your laboratory, we need to lengthen the incisal edges, say 2.5 millimeters. So that way we're not making the teeth gigantic, but we're getting a nice incisal edge position. And then our plane of occlusion, we'll talk about this, but our interior aesthetics will all fall from there. Another nice thing about having good pre-treatment models is when you're all done, you can, the patient might have some inaccurate recollection of where their teeth were, and it's a good place to be able to go back to and say, hey, here are the photos, here are the models that show where we started and the great progress we've made. So we'll get those models back in the laboratory. We'll get them mounted up based on your CR bite or your habitual bite, whatever you've decided from a treatment perspective, and then we'll duplicate and cross-mount them. And cross-mounting just means we'll put the model, the duplicate model, in the same position as the master model. We're going to want to set those master models aside because those are our point of reference. So we'll start out by extracting any teeth that you know need to go, and then we'll kind of decide how we're going to shape the ponics. Ovate ponics, which are kind of little egg-shaped projections that go under the tissue, give the most aesthetic result, and they're also usually quite hygienic. They're easy to deliver in an immediate situation. They are going to require a little bit of surgical intervention on a healed ridge, so you'll kind of want to make sure you decide what ponics you want. Keep in mind that modified ridge laps are often easier to use, but they are very difficult to keep clean. And so again, you'll want to think about and present to your patient the pluses and minuses of various ponic designs. And then this is really important. We want to look at our gingival symmetry and relationship of the gingival margin to the upper lip at high smile. Again, part of this is coaching our patients so that we see the high smile, but we want to make sure that we don't see more than 2 mm of gum below the upper lip at high smile. If we do, that's usually a gummy smile, and we need to talk about this. So we need to kind of look at two aspects of this. One is do I think the gingival display looks good, and is the patient happy with the gingival display? The second thing is are there significant gingival asymmetries? Because if we have like a small change, maybe 1 millimeter, we can sometimes change the depth of our preparations in the sulcus in order to even that out. But if we have major asymmetries, we'll probably need some crown lengthening. And again, this will be important for staging and kind of talking about how do you provisionalize a patient? How do you get a nice result during healing? If you want, you can see in this photo, once you have a mock-up, your laboratory can make a plastic splint from the mock-up that shows the desired gingival position. And then your surgeon, when they do the crown lengthening, will alter the bone to be 2 or 3 millimeters below that to give a nice predictable result. So we'll talk a little bit about tooth position. As we mentioned before, the incisal edge position of 8-9 is critical for aesthetics, so we'll set that. Then we'll have evaluated the gingiva, so then we have the length of the central. From the length of the central, we can find everything else. We know the width of the central should be, this picture shows 80%, so it depends on the patient, somewhere between 72 and 80%. We want the total surface area of the laterals to be 80% of that. We want the total surface area of the mesial aspect of the cuspid to be 80% of the laterals. We align the incisal and gingivals, usually of the cuspids, with the centrals, and then we'll make the incisal edge of the laterals 1/2 to 1 millimeter shorter and the gingival 1/2 to 1 millimeter more coronal. So I guess you could say shorter as well. So following those rules, you can see that once we have that length of the central, everything else follows from that. The other thing we need to look at is buccolingual tooth position. As you know, the buccal position of the maxillary teeth sets the lip support. So if your patient is not happy with their lip, wants a little bit more support, If you're doing a bunch of ponics or implant supported case, it's easier to move them. If you're doing all tooth supported teeth, it's more difficult because it tends to make the buccal bulgy. So again, if you talk with your patient and they're insistent on moving tooth supported teeth in terms of tooth position, you want to make sure that they see what the aesthetic implications of that are and that you guys work through that together. Obviously, as you know, tooth position also affects our phonetics, so we want to make sure that our centrals touch the wet dry line. One other thing that's really important is where you position the midline. As you look at this case, if you look at the mesial gingival line angles of number 8 and 9, you notice that they're very symmetric. It's critical that when you position the midline, you want it to be vertical relative to the face or perpendicular to the inner pupil area or whatever looks best for your patient. We'll talk about that in a minute. But in terms of the horizontal position, you want to align it midway between the margins of 8 and 9. If you bias it one way or the other, it's almost impossible to fix the emergence profile problems that emerge. So we position the horizontal location of the midline based on optimal aesthetics. One other thing to keep in mind, and this is true for all your anteriors, but especially for 8 and 9, everything you can do to prepare the teeth symmetric at that midline gives a better result. Couple other little tips, especially if you're doing a whole bunch of conics, it's generally nice to put the centrals flat to the front. Sometimes we angle them just a little bit to follow the curve, but basically we want them in profile, and looking at them from the incisal, we want them flat. We want cross-arch symmetry, whatever we can do, and we'll talk about orthodontics and the like. We want to make sure that the centrals and the laterals are symmetric. Studies have shown that most humans perceive beauty and symmetry as being synonymous, so our patients will generally think their teeth look better if they're more, what am I trying to say? They're more symmetric with each other. Want to look at our line angles, and then if we have some dark triangles that we need to close, your laboratory will probably know this, but it doesn't hurt to remind them. We want to close those from the lingual. We want the buccal surface to look ideal for aesthetics, and if we have to do some over contouring to close those dark triangles, we'll want to close them from the lingual. Last but not least, we want to talk to our patients about facial asymmetry. You know, if a person has their nose has a bit of an angle or their eyes a little bit misaligned, that's okay. And again, we don't want to make them feel self-conscious, but when we're trying to set the dental midline and the incisal plane and all that stuff, those have to be referenced to the face. So if we're going to see some challenges, we want to discuss those ahead of time and address them in our mock-up so our patients can see what's going on. So we've done all our analysis and we're going to start working on our mock-up. There's a couple ways we can do that. Most basic way is kind of a photo orientation Photoshop method, where we'll take some, kind of like the last picture, we'll take some idealized teeth and we'll put them into the patient's photo. These can look pretty cool, but the challenge sometimes is replicating it. When your patient says, "Can you deliver this?" You're like, probably, fingers crossed. Oh yeah, absolutely. Another way is to do this physically. We can do a diagnostic wax up, either physically like we see in this picture, or digitally with a milled prosthetic to kind of show the patient, again, okay, but they're looking at something in their hand as opposed to in their face. If we're moving the teeth buccally, or if we can do that temporarily, what can be really nice is to design a PMMA overlay over the patient's teeth. Now, this can either be bonded to place for the patient to wear for a while we're doing the treatment. It's kind of a pre-provisionalization, or it may be something that we just put on like a snap-on smile real quick so that they can visualize it. If we're going to bond it, we can't really simulate crown lengthening because, of course, that'll create hygiene problems. So our teeth might be a little bit short gingivally if we're planning on doing crown lengthening. But but that can be a great way for the patient to actually see what we're proposing. And even if we're making some bite alterations, we can bond those as onlays to the patient's posterior teeth and let them kind of experience our proposed bite. Last but not least, we talked a little bit about facial scanning. I think this is where facial scanning really shines, because in a facial scan case, we can actually design the teeth within the patient's face, and then we can show them this is what your smile will look like, and we're designing in their face. So yes, we can 100% deliver it. That can be a great solution as well. So we've kind of talked about evaluation, and so we want to kind of have a methodology for presenting this to the patient. So first, we want to talk about structural issues. We want to talk about, like we talked about on the slide here, periodontics, endodontics. Are there treatments that need to be done to prepare the mouth for the definitive restorations that we're going to create? We want to make sure that if there's any active periodontal disease, that A, we get it under control, and B, we use our assessment of whether the patient's going to be able to keep it under control. If we see a patient who has a history of very poor home care, a fixed solution may not be awesome for them, because you know, peri-implantitis is also not the best, and we start losing implants, then we can have some difficult situations. So we may decide that we want to do a fixed removable, like a locator bar, a conus, or something like that, so the person can actually be successful with keeping their new restoration clean. Again, we want to talk about the benefits of endodontics as opposed to implant therapy and make our decision on that. You know, I feel like I've been in a couple study clubs with orthodontists, and I feel like orthodontics is an area that we should push a little bit harder on. The easiest way and the most predictable way to get awesome aesthetics is to start with the teeth in the right position. We'll often push hard for a multi-month crown lengthening, implant position, you know, things that require quite a lot of healing, but we'll kind of say, oh, orthodontics takes too long. Modern orthodontics has methods, as you guys know, to move teeth much more quickly. And I think we in situations where we need to get the teeth in the correct position, pushing a little bit harder on this will give our patients better treatment. And again, if they choose not to do it, then we can talk about the implications of that and that sort of thing. Also, if we have to extract any teeth, which we often have to do, we'll kind of want to plan our provisionalization. If we're going to do ovate ponics, and maybe let's say we have to extract one tooth, maybe the best thing to do is prep the adjacent teeth, make a provisional for the day of the extraction, so that we can start shaping that ponic. So we don't have to do a surgical intervention, but we can just let the person's bone and tissue heal to our ovate ponic. Implant placement. I heard this the other day, and this is really summarized so many things for me. Implant therapy is a prosthetic discipline with a surgical component, which is kind of our fancy way of saying people buy teeth, not implants. If we get an awesome implant position and the tooth that's on it is ugly and it can't be fixed, our patients are not going to be very happy about that. And one other thing we need to keep in mind is that with many of these cases, we're going to be moving the tooth positions to idealize them. Sometimes we'll be doing just a little bit. Sometimes we'll be making major movement. So we want to make sure that our implant positions are driven by the final prosthetics, not the current position. This is an area where, as the general dentist, you can help yourself by really supervising this process. It might include surgical guides. If you're doing surgical guides, make sure you take a PDS or an iOS for them, because the fit of the guide determines the accuracy of the surgery. It may be that you provide mock-ups for your surgeon so that way they know where the teeth are going to be. In any case, especially for single teeth, getting that implant the right size, so big implants for big teeth and little implants for little teeth, at the correct depth, so that we have the running room to get nice gingival emergences, and the correct position so that we're not warping the tooth form based on the implant position. Implants are a great way to replace missing teeth, but well-placed implants are a great way to replace missing teeth. If the implant isn't in the correct position, we're often going to wind up making aesthetic compromises to get that where we want it. When we're placing the implants, we also want to think about gingival shape, I guess you could say, in provisionalization. Stock healing abutments are usually round. There's a few that you can buy that are triangular depending on your implant system, but I rarely see roots that are round. So especially when we're dealing with any well-shaped gingiva is going to make a better restoration. But most of the time there's some cost involved in this, so we'll be thinking about this in the anterior region. If we make a round hole in the tissue, we're not going to get the ideal emergence. So there's a few different ways to deal with that. One way is that you can make a traditional custom healing abutment. So you'll take you or your laboratory will place an analog in the model, shape the model the way you want it, and then cut a temp cylinder down just above the gingival height and fill it up with some kind of resin. It works well. It doesn't look that great, but it does look well. I mean, it works really nice. And it's definitely better than nothing. Your second option is you can actually make a immediate temp crown, especially if you're doing guided. You're going to know where the implant is going to be placed ahead of time. So you can make a nice temporary crown. Part of this depends on patient compliance. These have to be out of occlusion by at least 0.5 millimeter in both centric and function, and the patient needs to know they cannot chew on it. It's only for show. That's good to say. Obviously, there are a variety of removable options. You can make a flipper, you can make a Nesbit. So there's some different options with that. I also want to call out the Atlantis custom healing abutment. As far as I know, this is the only thing of its type. Your laboratory can make a milled abutment that healing abutment looks really pretty and has ideal emergence profile. And then there's a workflow so that if you scan this with your iOS, you can actually have your final abutment, which can be either part of a cement retained or screw retained restoration with the exact same emergence profile. One of the things to keep in mind with custom healing abutments is that you have to find a way to capture that tissue. If you use an iOS, it's great. You pull the provisional or custom healing abutment, scan really fast while the tissue's up, then put your scan body in. If you're going to do an analog process, you have to make sure that you shape the impression coping. So that's a little bit more difficult. So iOS really shines in this area. So we talked about a template, and as much as possible, we want to show the patient what we can achieve. This is an example of how you can bond your PMMA on the teeth to show the patient what's going on. If you do this, it's great to bond it because then you just prep right through it as you're doing individual. All right, so now we get to sequencing. And I'm sure you guys have thought about this some, but just want to refresh your memory. Start with orthodontics because we want to make sure everything that we do references tooth position. We want to make sure it looks good. Then we should probably do our surgical component together. Place our implants, do our grafting, get our custom healing abutments in, do any gingival recontouring, crown lengthening, in other words. Make sure that we get our custom healing abutments in there. And then we want to deal with bite. We want to make sure that the patient has a way to try out the bite that we're going to use. We can use a night guard for this, and that can work well. One thing to keep in mind is you've got to figure out a way to mount the models, to mount the case to that night guard. So that's really important. It's probably better to do bonded onlays so that the person can actually wear it without wearing a night guard. And again, this is where kind of our creativity gets challenged a little bit. We want to make sure that we get the patient a good result all the way through the process. We want to make sure that once we're done with this, that we got the results that we want. We want to look at, especially at our gingival positions. If there's been any challenges, we want to make sure that we address those with the patient. Provisionalization. So we finally gotten the case all set up. We're ready to prep and provisional. I'd say there's 3 major ways to do it: the eggshells, matrix, and chairside position. Eggshells, your lab will mill a set of provisionals that are as thin as is humanly possible, usually 7 or 8/10, and then you're going to try to prep to that. It seems like a cool idea until you do it. It's very challenging because the margins aren't right, and sometimes they don't fit. So you wind up prepping the teeth to the provisional. You can do it. A lot of teams do it. Just make sure you understand the challenges of it. The second is a matrix. You make a very precise putty impression of your planned restorations. And then when you go to the mouth and you're done prepping, you'll actually fill that up with provisional resin and put it right on the mouth. The putty has to sit perfectly or you won't get the exact result that you want. The third option would be chairside milling, where you use your planned case, your wax up, your design, whatever you did, as a pre-op, and then use biocopy to basically mill a bunch of provisionals. When you're preparing the case, most times with these large cases, your patient's just going to pick whatever color they want. You want to make sure that you provisionalize them with that so that way they can kind of evaluate it before we go to the end. The other thing to keep in mind is most of the time we're going to be making the teeth lighter. There's a couple things that you can do in the prep process to make that come out a little bit better. One is align the incisal edges, both incisal gingivally and buccolingually of the prep, to make sure that they don't affect the all ceramic restorations differently. And then the second thing is that if you have really dark preps, it's good to base them out before you take your master impression. Again, do the work ahead of time to get a better result more easily at the end. Last but not least, we're not going to want to take a bite at this time because we've already established the bite on our study models. So one thing that can be very helpful is prep all the teeth that say 3, 6, 11, and 14, take a scan or impression of that, then prep the rest of the case. That'll help your lab. They can cross-map those models. When you're provisionalizing veneers, you really can't do eggshells. Probably the easiest way is to do a putty matrix. Make sure you spot bond, or else you're going to be taking those things, replacing them all the time. Again, when we're doing the case at this point, we're just trying to implement the plan we already made. So if you have to make huge changes, you'll want to make models, but otherwise we want to use the design models that we already have and just take some photos of what they look like in place. So use your judgment. If you made minor changes, take an impression to send that to your lab along with the photos. If you made major changes, we're going to have to, especially to the bite, we're going to have to remount the case and then use that as our new bite. So when you're doing the case segmentally, keep in mind that you want to do all the restorations in the anterior quadrant at the same time. You also want to use the same restorative material as much as possible. In your laboratory, it's best if the team works on a solid model rather than a pen model, so that way we get nice adaptation of the crowns to the gingiva to avoid dark triangles. Keep in mind that your lab will, the gingiva, as you know, is very irregular, so to get a nice profile, your lab will need to put a little bit of pressure on the tissue in those areas, so they may have to alter the model just a little bit. Kind of one of my general rules of restorative is that you want to make sure it's going to take X amount of time to do it. This process spends more time at the front end and it gets easier and easier as you go to the final restoration. You can also go a little bit quicker through the front part of it, the diagnosis and planning and all that thing, but it makes the final less predictable. So we want to work with that. Just a couple other things I wanted to mention. Most of the time when you're doing these cases, you need to find materials that have the appropriate mechanical properties and still are going to get the aesthetic results that you want. When you're doing adjacent materials, it's best to make them the same. If you can't, you'll want to choose materials that can look similar to each other. We'll talk about that briefly. Don't forget about gold crowns. Gold crowns are strong, they're biocompatible, they last forever. Really, the only thing that's wrong with them is that they're ugly. So if you have a patient with not a lot of lip mobility and you're restoring second molars, and especially if they see bruxism, don't overlook this as an option. Dental alloys, just want to talk about that very briefly. There's two basic categories. One is by mechanical properties, type 1 through 4, how strong it is basically. And of course, the greater strength and hardness is more important for bridges and the like. And then the other is nobility. Nobility in dental, as you guys know, is a little bit different than nobility in chemistry. It has to do with reactivity. So generally higher noble alloys will be less reactive. We don't do a lot with alloys these days. So one thing to keep in mind is if you have a patient that has challenges with allergies, we want to make sure you can reach out to your laboratory and get a sample of the alloy. There are usually special alloys that have been designed with a minimal amount of components to help prevent allergies. Zirconia on the maxilla, it can be nice to do zirconia crowns that are solid zirconia on the lingual and the occlusal, and then layered on the buccal can look really nice. Also with zirconia, you can mix and match. Let's say you're doing a bridge that's 3 through 5. You could do 3 as full contour zirconia, 4 and 5 is layered on the facial. The other thing to keep in mind about zirconia is really good for shade control. You have metal components on your implants or maybe a dark underlying prep, that can be a great that can give you a great result. Keep in mind that if you're going to do a layered restoration, you need to allow enough depth. You should allow about 1.5 millimeters of reduction from the final position, not from where the tooth was. So in other words, if the tooth was buccally verted and you're prepping it, if it was 0.5 millimeter buccally verted, you'll need 2 millimeters reduction. And then our last material we want to talk about is lithium silicate or disilicate. This can be done micro-layered or monolithic. With the kind of cases we're talking about, you'll generally get a more predictable result with monolithic. This is, I would say, the restorative material of choice for anything that has to be bonded, inlays, onlays, veneers, that sort of thing. If you're doing a case, let's say, where 2 veneers next to an implant crown, usually you're going to get the best shade match with dissimilar materials doing a layered zirconia next to a lithium disilicate. All right, well, that's all I have today. Thank you very much for attending. I really enjoyed this. I hope it was beneficial for you as well.
Have a wonderful day, everybody. Thank you so much. Bye-bye.